I think with that, I will introduce Andrew. I won't read all of this, Andrew. Andrew is the Director of Science and the Chief Scientific Advisor of the Health and Safety Executive. And he joined HSE in 1991 and basically is an important force within the Health and Safety, has been an important force within the Health and Safety Executive ever since. He also is the co-director of the Thomas Ashton Institute together with the field board. I'll leave it at that, Andrew,
Perfect.
if that's okay, and I'll hand over to you. And, look forward to your lecture.
Thank you very much indeed, Marty. Good afternoon, everybody, both in the room and online. It's obviously a huge privilege to be invited to give this lecture, and thank you to Marty and Neil and the university for inviting me so to do. So, what I'm going to hopefully convince you of during the next 40 minutes or so is that occupational health research delivered by government is a frontline service and not an expensive luxury. And hopefully, by using a few examples, talking through what the processes are, I'll not only convince you by the end that it is an important frontline service, but also perhaps describe a little bit about why research conducted within government is a little bit different from research conducted within other parts of the UK research system. Just as well, if you hear little pings going off in the background, it's people joining. That's what the pinging is, so apologies for that. But we all are guilty of joining a little late some days. Both. Right, so what I'm going to talk about for the rest of the lecture is a little bit of history. As Marty said, it's important to recognise that there's a long and really interesting history between ourselves as the Health and Safety Executive and our predecessors and the University of Manchester. Then I'll focus on doing research in government, what that means and how that perhaps takes you in a particular direction. And then use a few examples to illustrate that connectedness to frontline services. So, a bit of history to start with, and I'm very proud to be part of an organisation that has a very long history, obviously going back to the Factories Act, 1835, I think that was, but also from a research perspective, our research bit was originally set up by Winston Churchill in 1911, based originally out in Eskmeals, but then moved to Buxton 100 years ago this year. So we've been on that site in Buxton since 1924. And in our early years, we were very much involved in thinking about why so many people were being killed in coal mines. And you can see a picture there, top right, of some of the work we used to do where we invited miners to our site so they could see how coal dust explosions occurred and feel the pressure of the coal dust explosion in their chests, so that it was a bit of experiential learning that hopefully made them appreciate the risks that they were managing. Around that time, we worked very closely with the University of Manchester, and particularly through Marie Stopes, who you can see in the bottom left there. She, in addition to the work she did obviously on family planning issues, was an expert in coal and the fossilisation of wood to become coal. And one of her early claims to fame was that she dissolved coal for the first time to produce materials that could then be tested in a different way. So that was very much part of the early work with our predecessors from a research perspective, worked closely with Professor Wheeler, who set the facility up in Buxton in those early days. And then over years, many years, we developed a whole series of skills going forward. And of course, it's a great privilege to be speaking at the lecture in memory of Ronald Lane. And in sort of preparing for this lecture, I looked at one of the seminal pieces of work that he produced, where he certainly wasn't short on giving opinions about the state of HSE and our factory inspectors, and in particular our medical inspectors. And he made some really interesting recommendations, actually, which you can see, probably a bit to read, but I'll just pick a couple of them out on the right-hand side there. And the first was, this was back in 1961, he recommended the establishment of an occupational hygiene service backed by laboratories. So that's where I work today. I lead the science division of HSE and run the laboratory in Buxton. So he made a recommendation that I'm very proud to have followed through and now work in. So that's hopefully a very useful link. And then towards the end there at number 5, he says, the research facilities are excellent at present. The identification of problems and the transmission of results will be greatly helped by the Occupational Hygiene Service and by a network of trained factory doctors. Now, we have done that over the years, but we haven't got as many doctors as we used to have in HSE. But we do have a network of appointed doctors who are very important to us and provide us with some really useful information about the people that they see through the appointed doctor schemes that we run. So I think the ambitions of Ronald Lane are being realised, and hopefully through the course of my presentation to you this evening, I'll be able to demonstrate how I think that is an important frontline service that he identified all those years ago. Apologies for the pictures, but obviously as HSE, and it's important also to say, actually, you can see there, we've been protecting people and places for 50 years, and it was our 50th birthday yesterday. So the Health and Safety Work Act came into force on the 1st of October in 1974. So really pleased that in our 50th year I'm able to give this lecture. And we have had that long history of working closely with Manchester, so originally with Mary Stopes, and then through various projects that we've funded over the years with people like Nicola Cherry and Raymond Aegis, and obviously now with Marty. And it's been really important for us to ensure that those skills and capabilities are available to answer those really difficult questions, and in particular the surveillance schemes which enable us to look at the impact that we're perhaps having on the occurrence and incidence of occupational diseases over a very long time frame, going right back to 1989, is really, really important, and particularly with our emphasis on health. We've already mentioned the Thomas Ashton Institute, and again, really proud to be part of that leadership team with Neil. We've done some really fantastic work since the Institute was set up under the auspices of the University of Manchester and the Health and Safety Executive. And we have a number of themes within that which are really important, and we've picked because they essentially make best use of that combination of skills, knowledge, experience that bringing together the Health and Safety Executive and the University of Manchester brings. So I think our history is a long one. It's one that we can all be proud of, and it's delivered some really great work over the years. So thank you to Manchester, and long may that relationship continue. Okay, so let's move on to think a little bit about research in government, which is the theme I've sort of picked up on for this presentation, and posing that question right at the start about whether the research that we do can be considered as a frontline service. So if you think about a frontline service and what that actually means, the sort of dictionary definition is that people who are involved in frontline services deal directly with the public or support others who do. So that means obviously that the outputs from the work that you are involved with have an impact with those that need to use it. So for example, with ministers, so top left we have our current Minister, Sir Stephen Timms, who is the Minister for Health and Safety. He is working very closely with us since his appointment on issues close to his heart, like asbestos. So being able to directly influence the Minister, provide him with answers to the questions that he poses to us on quite complex issues like the epidemiology of asbestos is really, really important. Being able to sit in front of a select committee and be grilled about the work that you do is also part of that role. And clearly, as HSE, our stakeholders include members of Parliament. So being able to sit in front of that committee and be questioned robustly about the evidence that you're providing to support regulatory and policy activity is really important. In the middle, that's just a shot of our executive committee, so I'm really pleased to be able to input the evidence to our broader strategic thinking as a member of EXCO myself. So being able to talk about the science, being able to identify how it can help develop our strategy for the next 10 years is a really important aspect of my role, and being assured that the science and evidence that we use to make those decisions stands up to scrutiny is clearly very important. Working with industry stakeholders, making sure that they have access to our facilities and our knowledge to help address their problems, also really important. That might be from a net zero perspective, but also from an occupational health perspective, where we provide analyses that perhaps nobody else can do, which then directly impact how people do their jobs. For example, isocyanate exposure monitoring using biological monitoring. And then through our clinical relationships, so working with clinicians so that we can provide input direct to help with both clinical practice and standards of care, which I'll talk about a bit later on. So I think that gives an early indication that, I believe very strongly that we are providing support for those people who are directly involved in those activities that impact the public. And of course, one of the great things about working for HSE from a research angle is that we have a very short route to impact, which is another way of describing that frontline service in my mind. So what does that look like in practice then? So, and why does HSE need evidence to support the work that it does? As I say, the Health and Safety at Work Act came in 50 years ago yesterday, and the way that we sort of like to think about the interaction between the various elements of our work is in this triangle kind of model, where we have the responsibility to develop regulation and policy, and all of that is underpinned by evidence. And the integration of all of those factors together means that you can be a learning organisation. You can use the information from the inspectors to inform research questions. You can use the information that we're providing when we analyse that to support policy initiatives, etc. So that ability to work together across those boundaries becomes a really important feature of our regulatory model in the UK. And when the Act was set up under Section 11, it was already very clear that research was a critical component of the thinking behind those requirements for a goal-based regulatory regime, which is what we have in the UK. So you can see here that under Section 11 of the Health and Safety at Work Act, it was a it still is a responsibility that HSE shall make arrangements as it considers appropriate to carry out research and publication of research. So that's underpinning the reason for that research activity. And of course, we had to consider the most appropriate way to do that, and we chose to develop an in-house capability. So we have our big facility in Buxton, which sits in a site of about a square mile, where we have about 350 scientists, engineers and analysts working on a variety of issues relevant to HSE's approach. And that brings a number of benefits to HSE. It means that we're not always working on the issues of today. We're thinking about the problems coming towards us, be it artificial intelligence, changes to demographics, whatever it might be, to make sure that we've got a good evidence base to control risk where it's been identified. So it's all very well saying that's not good for you, but what can you do about it becomes really important. I've already said that the evidence base to underpin those policy and operational activities is really at the heart of what we do. We are an evidence-based regulator. We have to be because of the goal-based regulatory regime that we have in the UK, where those people who generate the risks are responsible for controlling them, and therefore if we had a prescriptive model, we would perhaps be stifling innovation because we'd have to change the regulations every time a new material was used or a new process was used. And as I said earlier, being able to use the knowledge that we generate from all of those interactions that we have with duty holders when we go and inspect, when we go and gather data from those places, is a really important research opportunity for us. And we have very good data analysts now who can use things like AI to mine that information for expert knowledge. And knowledge is critical to what we do, but this might be a bit motherhood and apple pie, but it's really, really important, because one of the differences, I think, between government research, research for government, and perhaps blue skies research is firstly the applied nature of it, but also the focus has to be laser tight, as it were. So, just to sort of explain that, clearly when you're thinking about knowledge, there is a pool of knowledge, things that we don't know. But there's also lots that we do know. As HSE, we need to focus on the things that we need to know, which will be both unknown and also published by others. But critical is this bit here, because that means that nobody else can do that. And that's where we focus our capability so that we can research those very specific questions in a very specific way and not replicate what others are doing. And that's a really important tenet of research in government. It's about focusing on the things that are needed and cannot be delivered by other people. So how do we identify the things that we need to know? Well, it starts with our strategy, which I'll talk a bit about in a minute. We also, as a government department, have to produce what are called areas of research interest. So if you Google areas of research interest, you will find the big questions that all government departments want to answer. And there are really useful resources that can help you trawl those documents to see what those big questions are. As I've already said, we can't do everything, so we need to understand what else is going on in the research environment that we're interested in. And therefore, we have to understand what other people are doing, both in the UK and overseas. So what we try to do, therefore, is exploit, influence and commission in the right balanced order, so that we are, as I say, focusing on those really critical knowledge gaps that we need to fill to address a policy or regulatory concern. I've mentioned our strategy, protecting people and places. This runs till 2032, and I'm sure you all know about this, so I won't obviously stress, sort of go over the points too much, but this is the set of words that we have around occupational health, and our objective within the strategy to reduce the incidence of occupational health with a particular focus on mental ill health. And you can see some important points there. Commonly reported causes, stress, depression or anxiety, and we will work to reduce this trend. So that is a commitment that we will do something about it. Now, the evidence base behind that is something that we are looking at, and we've identified some gaps that we think are really important for us to fill to enable us to do something about it. And that's what I mean about focusing in on the things that will make the biggest difference. Apologies, the words on this are a bit small, but essentially this is how we go about that process of addressing the knowledge gaps. Starting at the bottom is that whole issue of how you get the knowledge into the organisation from others who are involved in the areas that you're interested in. Of course, that means you have to get the processes right to do that. So it might be through common interest groups, it might be through calls for evidence, and some of you may have seen the call for evidence that we've got out at the moment on AI and also on mental ill health. So seeing what information we can capture from others. And clearly evidence synthesis is part of that process as well. We also ensure that our scientists, engineers and analysts are properly networked through things like standards committees, where you can gather really useful intelligence about industrial challenges and industrial changes, working through with other funders like UKRI, what they're up to, other departments to see what questions they're asking and whether we can work together to jointly answer questions. And of course, the engagement through academia, industrial partners and other regulators. That means that we can then focus on those things that we need to do. And we do that through lots of different ways, be it commissioning our own people, commissioning people from outside, or sponsorship of individuals through various approaches. And these are our areas of research interest. As I say, please do have a look at them. They are the way that we capture all of those big questions. And of course, one of the things that we have to think about when it comes to occupational health is that these are really hard questions. They're not things that you can solve with a quick, 6-month research project, given that you're often looking at complex systems, you're looking at many different factors that result in the outcome that you're interested in. And the interventions that you might need to address them are very complex in their own right. So actually being able to pull all of that together into a programme of research is quite a challenging task. Again, you won't be able to read this, but what I've tried to do here through some work that Chen has done, who's one of our strategic science advisors, is to sort of group the questions that we've asked into those 3 areas around the evidence needs, the priority health topics, and the regulatory strategy. And if you go to those areas of research interest, you'll find what we call areas of research focus, which are the things that we are trying to address at the moment. So things like setting standards, designing systems that enable us to capture exposure data. All of those things are in progress at the moment. But having that opportunity to capture the information is critical, because it also means that we can then work out what skills we need to do that. And again, it's not just about what we can do for ourselves, but it's about how we can encourage others to develop those skills, and then we can tap into the knowledge that they're generating. We have to think ahead as well, so using foresight to identify future risks, and again, ensuring we have a talent pipeline, either ourselves or with others, to address those challenges is really important. And again, working with the Thomas Ashton Institute, providing the opportunity to develop PhDs in some of those emerging areas is really critical to do. And of course, we access expertise from all kinds of areas, and there's just a few examples up here. Other government departments, international fora, cross-government collaborations. So I'm part of the Government Chief Scientific Advisors Network, and we meet weekly to talk about areas of concern across government. So being able to access all those different networks is a critical part of doing research in government, because you can't do it all yourself, you have to work with others. One example I'll just mention briefly is the Partnership for European Research in Occupational Safety and Health, which is an organisation involving 14 member institutes across 13 countries. And we run a number of joint projects where we're pooling our capability to answer some of those difficult questions. And by doing that, it gives us access to about 2,500 experts around Europe that otherwise we wouldn't be able to bring together to work in that way. This is some work that's been done by colleagues at the Danish Institute, where they've been mapping some of the issues against the capabilities in those institutes. And you can see a lot of commonality. And we have therefore established a number of joint projects together where we are combining our resources to answer some really hard questions, be it about algorithmic management and AI, or harmonisation of asbestos workplace exposure assessments, so that we can pool resources in a way that perhaps otherwise wouldn't be feasible at that European level. So understanding how that works, being party to those conversations, making sure that we're sending people to the right meetings is critical to that. And all of that leads us then to the practicality of answering the questions. And really important that we understand what the question is. And we spend quite a lot of time working out what the exam question is. And in particular, does that exam question align to an issue within the strategy? We talked about what other people are doing and focusing in on what we actually need to know so that we can get to that very specific question. As part of that, we need to know who's going to use the information, so who's going to be the end user. And also, this is something that perhaps is a bit difficult to explain outside government, but there has to be a risk appetite associated with that question. And by that, I mean very often policymakers want an answer quickly. And if you say to them, well, you can have an answer in 5 years' time when I've done my big research project, they'll say, thank you very much, I'll go somewhere else. So you have to understand their risk appetite for uncertainty when they're asking you for evidence. Now, if they want something very quickly, within a few weeks, then there is a duty on you as a scientist, engineer or analyst to have the conversation about the uncertainty that that answer would bring with it. So being clear about what the risk appetite is for the uncertainty of the science you're going to deliver becomes a really important conversation, and then nobody has false expectations at the end of the process. Understanding what the delivery driver is. So why is this needed and how quickly do you need it? What is the thing that you have to deliver at the end of this, and how is my evidence going to help you do that? Working with that end user to understand that journey is critical to delivering what they're looking for. And understanding what difference it needs to make through the routes to impact is also really, really important. And the way we do that is through these three areas. We just describe it as quality, alignment and impact. And I probably won't say more than that on that. So, that's some of the challenges of delivering research within the government environment. And what does that mean from a practical perspective? So we've already seen this, and this just reminds us that, that's the question I'm trying to answer. So let's use a couple of examples to hopefully demonstrate how I think the work that we do focuses in on those specific issues. And I'll start with an example from quite ancient history now, but still really, really important, I think, because it was a paradigm shift in how we thought about a particular issue, and that being occupational asthma. Many years ago now, I did some work with Stephen Gordon et al., where we went into bakeries and we looked at how they undertook their screening for occupational asthma using questionnaires. Not very exciting in its own right, but it gave some very interesting answers because, of course, we found that the questionnaires only told you some of the story. They were a useful tool, but they didn't necessarily identify all of the people that needed to be identified. In delivering the work, we were working very closely with an occupational health nurse who saw all the people and understood what was actually going on rather than what they were saying in their questionnaires. And by using her inside knowledge and using referral on to clinicians, we identified many cases of occupational asthma that would not have been identified through questionnaires alone. And then we said, well, actually, this is quite interesting. So let's do a little questionnaire of the workers to see why they're not telling the truth on their questionnaires. So we put a questionnaire in the canteen that said, do you tell the truth when you're answering your annual respiratory questionnaire? And a big chunk of them said no. And we had a little box say, why? Why don't you tell the truth? And a lot of it was because, for example, if they did say that they had respiratory symptoms, they'd be moved from day work to night work. They'd lose money. So there were incentives built into the way that their work was organised for them not to be picked up through these different systems. So understanding the complexity of the system was a critical part of understanding what interventions would actually work to identify cases of occupational asthma in this example. And then that led to some thinking about, well, okay, what have we done in occupational asthma over the years? Well, primarily what we've done is identify things that cause it. Is that going to reduce the incidence? Probably not. And at the time that we started this thinking, the Deputy Prime Minister, John Prescott, introduced some targets for HSE, one of which was to reduce occupational asthma by 30% over a given number of years, 10 years I think it was. So David Fishwick, myself, organised a workshop with clinicians and others, say, well, okay, how are we actually going to do that? Because identifying new causes is not going to get us anywhere. And this led to a whole series of different kinds of research activity. Lisa Bradshaw in the audience here did some great work looking, for example, at the routes of referral of occupational asthma. So, okay, we talk about occupational asthma, but how do you get that label? Well, many people don't have occupational health, so they go through primary care. Do primary care physicians know how to diagnose occupational asthma? Well, some do, many don't. And we found, for example, that some people took 20 years to go through the system before they were identified as having occupational asthma. And then what happens to you when you've got that diagnosis? You know, do you improve? Do you not improve? How do you get reported to SWORD? At what point do you get into the systems? So it was a completely different way of thinking about the problem, because we were focusing on what the end user wanted, i.e. John Prescott wanted to reduce occupational asthma by 30% over 10 years. And to do that, we had to identify the appropriate routes to intervene. So really important change to our thinking and a change to the way that we thought about some of these problems. Was that a frontline service? Well, I believe it was, because it led to policy interventions. It led to a standard of care being developed, which is, I think, still in use, and was based around the evidence that we'd gathered. So that's directly influencing the patients. It led to a whole raft of new research questions, a raft of different and new research questions. John Ayres did work on the true cost of occupational asthma, for example, looking to see where the cost landed, and most of it was with the individual and the state, very little with the employer. And it set up a group that's still going to this day, the group of occupational respiratory disease specialists, who meet to talk about these issues. They did not meet before this work was done. So really important changes in the way that we thought about these big questions, because we were focusing on what the end user actually wanted rather than what was nice to do, which was, let's find something else that causes the disease. My final example will be around COVID, and I was very privileged to run one of the national core studies during the pandemic, and this was a particular way of delivering mission-critical activities in real time. Just to sort of set that in context, HSE was very heavily involved in the pandemic, as you might expect, for a variety of different reasons. We were the market surveillance authority for PPE, so we had to make sure that all of the PPE coming into the country protected the people who were going to wear it. So set up systems to do that, and that was about 3 billion pieces of PPE that we assessed over the period of the pandemic. Lots of hard work by lots of people. I went to all the SAGE meetings as a Chief Scientific Advisor and was briefing our Secretary of State. So lots of direct involvement, again, with those people who were the decision makers. And as part of that process, Patrick Vallance asked if I'd run one of these big national core studies in July, specifically around the issue of transmission. So we worked very quickly to pull together a large consortia to deliver what we called the PROTECT programme. And really we were interested in how these three things interacted to deliver transmission events. So how the environment responded from a ventilation perspective, etc., how the people interacted in that environment, and how the virus itself behaved. And we did some fantastic work with Harwell, for example, through Neil Bourne, looking at individual virus particles and using things like the synchrotron to do clever, very hard experiments, which we wouldn't have been able to do otherwise. It was important that this was about the real world. It wasn't about blue skies research. It was giving information today about things that would make a difference. We had a number of themes with theme leads, driving that to specific elements of transmission, and we learned a huge amount in a very short period of time. We had money behind it, so the money was only guaranteed for 1 year after another, so it wasn't fully for 3 years, which did bring some problems, but it meant that we had money to tackle the problems. We had lots of people involved, we had lots of projects being delivered, and as a consequence of that, we got lots of publications out of it subsequently. But the most important thing was that we were dealing with the real world of work, and those really challenging times where people were trying to work out exactly what they needed to do to protect their workers when the pandemic hit. And you can see some examples there of, social distancing, making sure that people had the instructions available to them. The one on the top left is a smoking shelter where people are separated by cones so that they don't infect one another as they're having a drag. One of the things that was really important, again, Chen was involved very heavily in leading this work, was around outbreaks, because you'll recall that there was a lot of concern about meat processing right at the start of the pandemic, and concerns that that might have to stop because was that a driver for infection? Well, one of the things that we were able to do was to take the data and normalise that using our national population database, which is something that HSE run on behalf of government, because that data of the number of workers in particular workplaces, that was the only place it was available from. So we could get outbreak rates rather than numbers of individuals who were developing COVID in any particular environment. And you can see there that if you look at just the numbers, you would get a very different answer from what you get if you use that rate determined by the National Population Database. So being able to provide that information into the centre in real time was critical in focusing activities such as our spot check inspections from an HSE perspective. And then when we started to look at outbreaks and investigate them very thoroughly so that we had a really good idea of what was going on, we started to realise that actually it's not just as simple as saying there is an outbreak in this workplace and that's it. Because what we were looking at was an incredibly complex system. So, for example, we knew that people were taking precautions for shared transport, for example. A lot of the logistics centres are not served by public transport, so people were sharing cars. Rightly, in the risk assessment, they said, well, it's not a good idea to share cars because that's an opportunity for transmission. So we're going to ask you, we're going to pay you to use a taxi, and we're going to give you the money to come to work in a taxi every day. What actually happened was they gave them the money, and then they drove to the workplace together in a shared car, but parked a little bit further away, and then walked that last bit with social distancing. Because actually the issue was they were on 0 hours contracts. They didn't have the opportunity to self-isolate, because if you're on a 0 hours contract, you don't get paid when you are not working. And they needed the money. These are very low paid jobs, often with migrant labour behind them, often in multiple occupancy housing. And it's only by unpicking all of this that you can work out how the routes of transmission actually occur. And then again, you can appropriately intervene and provide advice, etc., to support effective control of exposure. Massive study, huge numbers of people involved. It's like a 4-day symposium. So that was a very quick wander through. But these are the kind of things that we learned, and I won't go through them all. But clearly work was an important determinant of risk. The job that you did often determined the likelihood of you becoming infected. We did a lot of work actually on some of the virus characteristics. So we know that virus survived on skin and was infectious when physically transferred to the nose using various animal models, etc. So there was a point at which people felt the transmission via surface to transmission wasn't happening. It probably was. It probably wasn't the highest cause of transmission, but we felt from all the evidence that we gathered that it still was a potential route of transmission. So those measures that were being taken to prevent that were important. We did some work using the human volunteer studies where we could show that only 10 infectious units were needed to infect someone. So, not very much virus is needed to make somebody ill. And we showed that individuals varied significantly in their emission of the virus. So not everybody was the same. And this sort of backed up some of the thinking about super spreaders, etc. So you can start to see how all of that information provides us with a way of quantifying those interacting factors to leave as our legacy for those who come after us and who will be investigating future pandemics, because we know that COVID's here to stay. We know that there will be a next time. We know that exposure was a continuous risk, which varied depending on a wide range of risk factors. And as a consequence of all of that, we need to make sure that we build resilience into our systems and processes. So a really important set of activities that were targeted at the end users. We were meeting frequently with chief scientific advisors from across government so that we could input directly into policy activities that they were involved with. We were running workshops with key players from national sporting agencies, London Underground, cruise liners, etc., to go through risk assessment processes with them to help feed this new information in so that they could put the right controls, etc. in. So real-time activity and real-time impact. But I think as well there were some intangible benefits from the work because it was globally unique in the way that it tackled the problem. And that came, I think, from our understanding of how to do science that was directly influencing end users and having an impact very quickly. That route to impact was very short. And that ability to drive mission programs, I think, is something that will be taken forward as we move into other big challenges like net zero, for example. It also worked across the UK science ecosystem, working with public sector research establishments, academia, private organisations, which is not easy to do when you're setting up a research grant, for example, with UKRI, because they don't necessarily pay everybody the way that they need to be paid, given the status that they have. And it importantly, I think, showed that occupation isn't a thing, it's a system. And that will be very helpful to us when we take COVID out of that particular equation and start thinking about how we tackle other problems. And just to acknowledge all of the work that was done by huge numbers of people across a wide range of organisations. And I've said this, that we were directly inputting into the Downing Street briefings, and you'll note that we managed to change the rule of three paradigm by adding ventilation onto hands, face, space, because the work we were doing demonstrated the importance of that airborne route of transmission. So that was an important sort of development that our national core study was able to support. And it was under lots of scrutiny by select committees, by Secretaries of State, so I say briefing them regularly to make sure they had the right information when decisions were being made, really, really important. Okay, so just drawing to a conclusion then, that's two examples, but is two enough to convince you that actually the research that we do in government should be considered as a frontline service with those short routes to impact? And of course it isn't, because there are lots of other examples as well. Asbestos, we are directly influencing the policy on asbestos by going out and measuring it, by working very hard to understand the exposures in different scenarios, particularly in those people who are removing asbestos. I mentioned the personal protective equipment during the pandemic. That was a direct impact on the PPE that was available to people working in the National Health Service, working on the basis that it had to protect the people who were wearing it. We didn't want to let any old tat in. It had to be able to stand up to the scrutiny of the standards that it was supposed to meet. Isocyanates, where we're providing tests for people to demonstrate whether they are exposed or not, whether they are controlling the exposure better than the person working next to them using biofeedback. And we've developed methods to assess exposure using biological monitoring. Currently, with the problems of engineered stone, we're testing the control measures that are available to see if they actually work. So it's all very well suggesting what might be suitable, but if they don't work, then that's not going to help anybody. And then around work-related stress, we've got a tender that's being delivered by Affinity Health at the moment to make sure that we are answering the right questions when it comes to the things that we need to understand to enable us to enforce in that space. It's a really difficult area, really hard to solve, so we are investing in the evidence to give our inspectors the right information they need, ultimately, hopefully, to enforce around work-related stress. So my final slide, hopefully I've been able to convince you that research, science, engineering, analysis, however you want to describe it, is a frontline service. It's really important to focus in on those things that we need to know to enable us to be effective as a regulator or a policy maker, certainly when it comes to health and safety. And as part of that, we need to make sure that we're all clear as the research about who's going to use that information, and to make sure that we are delivering it to the right quality by understanding their risk appetite, by aligning it to the appropriate strategy, in our case, protecting people and places, and that we are tracking the impact that it has with those people who need to use it. So thank you very much for your attention. Hopefully that has been of interest, and I'll stop there and pass back to Martin. Thank you very much.
Thank you, Andrew, for that excellent kind of lecture on the kind of need for, I guess, research and evidence to deliver effective interventions and government interventions. So we have plenty of time for questions from both the audience and online. So, are there any questions? Damien, I think we don't need a microphone. I think, but you need to kind of speak loud if you can, please.
I'd like you to challenge Andrew. Thank you for your presentation. Can you say a little bit about how HSE prioritises what it needs to know and how it currently balances the short and longer term needs?
Yeah, it's a really good question, Damien. So I don't know if everyone online could hear that, but Damien's asking about how we balance the sort of short and long-term needs and prioritise. One of the things that's really important is that we do that at the organisational level. So we have regular meetings with our executive committee, first of all, to set those big questions that we need to address. And we then have a series of other sort of groups that look at that prioritisation approach. Part of that clearly is dependent on the resources available to us and what other people are doing. So what we've done recently is appoint 5 strategic science advisors. These are senior people who have the job of making sure that they are tracking what everybody is doing in the space that they're responsible for, and each one has a strategic objective assigned to them, so that they can look at what others are doing. So that's, you know, what other people are up to. They can work collaboratively across organisations to make sure that they're influencing what it is that others are doing to help us fill gaps in that way, but also to focus in on those priority research questions, some of which are short-term, some of which are long-term, depending on what the needs are. So, for example, we've got a number of long-term projects, asbestos workers database, the SWORD scheme that we fund, the pesticide users database, those things that we continue to gather data on a sort of continuous basis. But also short-term things where it might be about the engineered stone is a good example. You know, we need to know that very quickly to know whether the controls that are being used are appropriate for the activity that we're trying to reduce the exposure from. So mixed approaches, but primarily through our new strategic science advisors, who are the guardians of the evidence for the organisation.
If I may ask a question, you know, that since I kind of moved to the UK in the early 1990s, I think there's, you know, in generally there's been quite a substantial decline in the amount of budget that's available for occupational health research, not just from the HSE, but from other sources as well. So how do you deal with, how do you, I mean, and COVID was an interesting example because that was a very acute emergency issue and quite a lot of budget was, you know, became available at a very short period of time. Now, mental health stress has been, you know, around for quite a long time. It's much more difficult to, you know, activate, I guess, that amount of budget, which probably realistically is also, you know, required to really kind of solve that that area. So what's your view on how we should, what opportunities there are to try to make best use of that limited money, and perhaps how do we try to convince the people who have the money to that there is really a need to increase budgets in these areas?
Yeah, I mean, the easy answer is say, you know, I'd love to have more money to spend. Yeah. Well, I would, but I haven't. So that means I have to think differently about how we do that. So if you think about stress, for example, what we were able to do there was to park some of our posts internally and use the money that we were saving for a few years to invest in research in that space so that we could balance off that, filling posts that perhaps might not have been the right skill set given where we needed to go by funding some extra mural research. I think as well we always look to work with others, so Joe Harris-Roberts in the audience has been working with other departments to see if we can't get joint projects funded where, for example, Department for Health and Social Care have an interest in mental health as well. So what can we do together to leverage money that perhaps they've got more of so that we can answer questions in different ways? I think the research councils have become more interested in some of these things, and again, it's really important that through our areas of research interest, we're flagging those up to the research community so that you can see what it is that we're trying to address. So I think, ideally, yes, I'd love, another £20 million. If you've got it, I'll take it, a check by the end of the lecture. That's not going to happen, so you need different ways to do it, and we're trying to make the most appropriate use of the vehicles that we've got to do the right things in the right order.
So I've got a question on the line for you, Andrew, from Paul. Asks, great presentation. Are there obvious changes that are emerging from the COVID inquiry, such as understanding of risk assessment and infection prevention professionals that you think are being put in place for future pandemics?
I think clearly, and thanks for the question, Nick, the point of the COVID inquiry is to learn lessons. That's the first point to make. And as it moves through the different modules that it's working through at the moment, those lessons will be learned. So I think they've already reported on the lessons from Module 1. Module 2 is going through at the moment, and future modules will collect evidence from people like ourselves as appropriate to ensure that all the information is going in to the system. What that means in terms of changes, I think we'll have to wait and see. But clearly there are a huge number of lessons to learn from what we experienced. And I think it's doing that in an objective way, using the best available evidence. Again, working through what the good evidence is and the bad evidence is to enable us to properly learn as opposed to think we've learned is really, really important. And clearly the processes that we're currently going through are designed to do that. So I think we have learned some lessons. There will be more to come, and let's wait and see what that can tell us about any future response to those kinds of issues.
Dave.
Andrew, thanks. Really enjoyed your talk. You talked about research at HSE having to be appropriate and laser focused, but all the sort of easy stuff's being done now, and now we're getting into the harder territory. Example, you mentioned work-related stress. So how does HSE, and obviously I'm part of HSE, but I'm interested in your view, how does it develop its stance, something like work-related stress? Who do you listen to? Who don't you listen to? And how do you develop research questions when there are probably an infinite number that you could develop in that area? And could AI and new techniques help HSE prioritise whether it really should be researching these really complex systems problems?
Yeah, it's a really great question. I'd expect nothing less, David. So that's thank you for meeting my expectations. I think it is very hard. I mean, these are not easy things to solve. If they were, as you say, we'd have done them ages ago. Lots of people are working on this, both nationally and internationally. So it's important that we take that global view and not just think about what we need to do in the UK. I think it's important that we do listen to voices from outside and make sure. That's why, for example, we've gone externally with this particular research proposal, because we wanted to get a different perspective on this and to really focus in on the things that we need to do to make a difference. But it's hard, and we won't get it right all the time. I think that's why it's really important that we track the routes to impact so that we make sure that the things that we do actually make a difference, rather than just saying, well, we've done that now, let's put that report on the shelf. It's also really important, as I've said, to make sure that the person who needs the information is working as part of the team, because we need to be very clear about why they are asking the question. But ultimately, you have to focus in on those things that you think are going to be the killer questions to address the issue at hand. And that, I say, we'll never get it right all the time, But by going through the processes that we go through, using our strategic science advisors to synthesize existing evidence, to identify the gaps, to work with others to see that we're not duplicating, I think that gives you the best chance of doing the right things. But if you've got a better way of doing it, I'd love to hear it, because it is a really hard thing to actually achieve.
So I've got another online question for you, Andrew. So this is from Hamad Khalil. What are the most pressing occupational medicine challenges you foresee in the next decade, particularly with the rise of remote working and AI transformation?
Well, there's two for a start. I mean, obviously, the pandemic has changed our approach to work significantly. So hybrid working has brought with it many opportunities, but also many disbenefits as well. And I think understanding the longer-term impact of that on worker health is going to be really important. I think we've perhaps got some generational issues that we need to think about. So, you know, I'm very conscious that some of our early years researchers, when they did their degrees, they did them in a computer. They didn't do it with real people around them. And that brings with it, you know, some different challenges for us as an employer to make sure that we're providing opportunities for them to be more interactive in the workplace. So I think understanding the legacy issues from a mental ill health and sort of a work process activity is going to be really important. We're decarbonising our economy, so making sure we understand the risks that are associated with how that needs to happen is really important, and that's everything from exposure to a range of different chemicals to new hazards, climbing up and down wind turbines, for example, to service them, and some of the risks associated with that. Now, AI could be a threat, but also a great opportunity, as David said, you know, to use AI to help focus in on key research questions, to help with regulatory approaches, to help screen drugs is something that isn't just for tomorrow, it's happening today. So for me, I think not forgetting that there are old risks emerging in new industries as well as old risks still around in some of the industries that have been around for a long time is really important. There's often a desire to chase the new, but actually we've still got an awful lot of people who are exposed to nasty things in industries that have been around for many years, where exposure isn't controlled, and understanding the systems model behind that becomes really important, as I've said, to make the right interventions. So plenty to go at. If we can find the money, then we'll be able to solve quite a few of those, but really hard things to do.
I wonder if I could... Oh, no.
Sorry. I'm not a scientist, I'm a lawyer, but what fascinates me is that you gave two very good examples of the fact that it's not necessarily science that decides things, it's the way people behave. For example, people aren't going to tell occupational health that they've got a health problem if they're going to lose their job or not get in the first place. I don't know if you've seen this Morrison's case, where the Court of Criminal Appeal has held that an employer has a duty under Section 2 of the Health and Safety at Work Act to look after an individual where they have to make a reasonable adjustment for an individual, which I find, you know, quite surprising, but there we are, that's an important new development. And I've heard a lot of employers say, oh well, yes, well we're not going to employ anybody with epilepsy, which is that particular case, you know, because, you know, we're going to have to pay 3.5 million fines and so on. So, and you talk about, you know, the bakery workers. Well, of course they weren't going to tell people because they didn't want to go on nights. Of course they weren't. Why didn't that occur to somebody? And it's very interesting that that nurse was the one who actually told you that. So I think, you know, the sort of the human reaction part of it is a very important aspect, I would have thought, of this kind of research. Is that
absolutely true. And, you know, any system is perfect until you put a person in it, because the person will not respond in the way that you think to that system. It depends on so many different risk factors. And, you know, clearly the complexity of that work system is something that we identified very clearly during COVID as being important to understand. And because people are at the heart of this, making sure that the way that they sit within your processes, the materials they're using, the demographics that they come from, the pressures that they're under, you know, outside work. All of these things will ultimately influence how they behave within your system. So if you don't understand that, you miss the opportunity again to do the right things. Now, in the case of the bakery, of course, the bakery weren't bothered that people didn't tell them because there was no consequence for them.
It wouldn't be liable.
So, exactly. So, you know, it was a thing that was happening because nobody was saying, well, this is wrong. This is not what this is for. So understanding that becomes really important. And understanding the drivers for the employers and the employees also becomes really important, which is why this systems-based approach to understanding the complexity of work becomes critical, I think, to making sure that you do the right things to sort the problem out.
And having somebody who's near to the workforce who knows what's
exactly.
going on.
Yeah, exactly.
By the way, I thought it was an excellent lecture, and even I understood it.
Thank you very much.
I think some of this also, you know, links back to the previous late lecture by Nicola Cherry, who basically kind of argued that maybe, I won't go as far maybe as her, but she argued that, you know, we really need to have workplace investigations rather than just do data linkages and big data sets.
And
because
I think
that
the
richness
nurses,
of information.
you know, I value occupational health
Yeah.
nurses, and I think they're often very much closer to the workforce, and they have a big contribution to make.
Absolutely.
That's an online question.
Another online question for you, Andrew, from Gordon Lanston. And Gordon's asking, in terms of HSE collaboration, to what extent are environmental health factors included in the research and in achieving HSE success, e.g. during COVID? And how valued are EHOs as a frontline environmental public health service in the future, considering the current dire state of the UK local authority budgets?
I mean, absolutely, EHOs, the whole local authority system is really important to HSE. And, you know, HSE doesn't regulate all workplaces. Local authorities regulate some workplaces on our behalf under the Health and Safety at Work Act provisions. So, really important that we've got well-qualified, well-trained individuals out there in the field doing what Diana said in terms of being the boots on the ground who can go and see what's really going on in these workplaces. So, yep, they are an important part of the system. Obviously, our board includes representation from local authorities as well, so that's really important to us because it's a critical part of the system. Now, you know, obviously, the financial side is perhaps a separate conversation, but clearly there is not as much money as there used to be, so that means we have to use the resources available to us perhaps in a different way and a more focused and targeted way. And one of the things that we're looking at in HSE is how we can use things like AI, how we can use the data and intelligence that we gather as part of our inspection activity to better target our inspectors to where the risk actually is. So that means that we can have a bigger impact over time using fewer resources than we've had perhaps in the past to do that. So I think, again, you can use evidence, data, science, whatever you want to call it, to help focus those reduced resources into the areas of highest risk, so that will ultimately have, you know, the benefit that you're looking for in reducing risk across the whole UK system.
Yeah, Richard?
Thanks, Andrew. A question about CSA rules. What, as a CSA, do you think the community will learn in terms of how to be able to organise evidence in ways to help ministers make effective decisions, and what could be done to help drive efficiencies in the way that the CSAs organise evidence across departments, particularly those across scientific advice mechanisms?
Yeah, it's a really interesting question, and of course, Chief Scientific Advisors have been around for a while now. I've been around as one for quite a while myself, and it's been interesting to see how it's developed over time. Before COVID, obviously, SAGE was convened for various emergencies, including the Salisbury poisonings, which I was also involved with from a SAGE perspective, and seeing how that community has developed as a cohesive group, I think, has been really impressive. So we've always met frequently, but we now meet frequently with knowledge of each other's activities, and we are joining up across topic areas. So, for example, working on net zero jointly with DESNES, Department for Transport, where we each know what the key questions are and what capabilities we have to answer some of those questions, what work has been going on. For example, we do a lot of work on liquid hydrogen, how that feeds into the transport space, wider space for greening the economy. That's working much more efficiently and effectively than it ever has done whilst I've been a Chief Scientific Advisor. And that's because we are a team and we meet as a team and we do activities, away days as a team. So we can, build relationships. It's the quickest way to get anything done in Whitehall, to be honest, because, I can pick up the phone to any Chief Scientific Advisor across government and we know each other. We've got, the relationship established. And that makes a huge difference in making sure that the information is flowing in the right way, at the right pace, to address those important challenges that we all have to face. Ignoring some of those departmental boundaries that can often get in the way because you're working across the boundaries through that team model.
I'll have one final quick question from
so I've got the two online, so
this quick one.
Is it the one on fatigue or Brexit?
Are the two linked in some way?
We can audience vote.
Pick the first one.
I was going to say the question on fatigue was posted first. So thank you, Professor Curran. Fatigue relating to circadian dysregulation in shift work and long hours has been a neglected area in healthcare and is widespread, especially among those living with energy-limiting conditions. Fatigue is an important factor in the NHS current crisis, given high rates of burnout. Does HSE have any plans for a review of regulations to improve fatigue risk management?
It's a really interesting question, and David and I did some work a few years ago where we sent a questionnaire around to, I think it was people just starting work, wasn't it? It was sort of like apprentices. And fatigue came out as the top issue for that group of individuals, which was a surprising result from that work. So clearly fatigue is an issue. When it comes to the evidence base, obviously that would need to develop before we took any sort of regulatory activity. But I would certainly see it as an issue that goes on the list of things that we need to understand better, given a 24 hours culture, given the way that people work in different sort of platform type economy issues. I think there's some important work to be done in that space. But no changes planned at the moment from a regulatory perspective, because the Health and Safety at Work Act is itself, if you like, because it's a goal-based model, it means that the people who are creating the risk, and if that risk is of fatigue, then they need to undertake a risk assessment to make sure that that risk is properly controlled. So the duty lies with the employer to make sure they've got the right systems and processes in place to manage that.
It's a topic that maybe within the Thomas Ashton Institute we will kind of pick up, because we've been recently approached and so by the UK BioClock consortium that also includes. Yeah. Anyway, I think it's 7:15. I'm sure you're all thirsty, so I think I would like to end this session now again with thanking Andrew for his excellent lecture.
Thank you very much.
Before we do that, I just need to have one quick slide. So before I let you go, and to show you how incredibly efficient we are becoming, I can already kind of announce you the speaker of next year's main lecture. I don't think we've ever done that this quickly before in our entire life. So we're really pleased to say that Professor Malcolm Sims from Monash University, and previously the editor-in-chief of the Occupational Environmental Medicine Journal, will be in Europe next October and has agreed to give the main lecture sometime in October. We will confirm the date closer to the time, but hopefully you all be joining again for that next year. So thank you very much, and drinks and nibbles are upstairs. Thank you.